Treatment for metastatic prostate cancer has changed in the last few years. When we have a patient with metastatic prostate cancer, one of the first questions we need to answer is whether this patient or this disease is going to be sensitive to androgen deprivation therapy or not. So for metastatic hormone-sensitive prostate cancer, we now have data from several large phase 3 trials showing that the combination of androgen deprivation therapy plus androgen receptor target therapy, such as abiraterone or even enzalutamide, or chemotherapy, such as docetaxel, improves clinical outcomes compared with androgen deprivation alone. When we have a patient with metastatic castration-resistant prostate cancer, assuming he progressed on ADT, we have 6 life-prolonging therapies available. Now, that all changes because if we are using one of these 6 life-prolonging therapies early on in the context of M1 hormone-sensitive setting, then we are less likely to use it again in the castration-resistant setting. And so other options in the castration-resistant setting are dependent on what we chose for that particular patient in the hormone-sensitive space. Treatment sequencing in metastatic prostate cancer remains a very, very important question, yet not completely answered. We do have a number of different systemic treatments that have the ability to improve clinical symptoms and improve overall survival. The question is, do we really know, what's the best sequence for patients with metastatic prostate cancer? And what we know so far is, in general, we don't. All the studies we've been conducting suggest that it might not be one-size-fits-all answer, and we might need to take into consideration patient characteristics, disease characteristics, site of disease, etc., and to help us define what's the best sequence of therapies for a specific patient. So when I think of all the sequencing of treatments available, I have to say that in my institution, the availability of clinical trials also impacts the treatments I'm going to choose. But in general, I would say that a good proportion of my patients will start by an oral androgen receptor target therapy, such as abiraterone or enzalutamide. And at time of progression, the clinical trials available in that setting, site of metastasis, clinical performance status, patients' beliefs and do play a role in, and also genetics, they all play a role in what's the next treatment I'm going to choose for that particular patient. In this particular patient, I fully agree with the way he has been treated so far. So perhaps if I were to treat him today, we now have data suggesting that he might have benefited from a combination of androgen deprivation therapy plus something else, which could be docetaxel or even abiraterone in the M1 hormone-sensitive space. However, back in the days, we didn't know that, and so offer him androgen deprivation therapy was the standard of care. So once he progressed, offer him enzalutamide is a very reasonable option. Other options would be reasonable as well. He was bone-only disease, not a lot of bone mets, so I would argue that abiraterone would be another reasonable option as well. I would probably have, would have done the same thing, which would be, save radium-223 for when I would see, I would have more metastases which happened to him at time of progression on enzalutamide. And so I think that offering him radium-223 after enzalutamide was a very reasonable option because he allowed him to get all 6 cycles of radium, kept his performance status at a good level, and did not compromise future options for him. And we can see that, by thinking that he, was offered chemotherapy 1 year later. And so I agree with the general approach to this patient.